Approach to Chest X-rays by Thomas Quash under supervision by Dr. Jaffer and Dr. Chung. The objectives of this presentation are to provide a general overview of chest X-rays, to review the normal thoracic anatomy on chest X-rays, and to develop a methodical approach for reading chest X-rays. In general, chest X-rays are usually the initial imaging study in patients with suspected thoracic disease. The standard views of a chest X-ray are the erect posterior to anterior and the left lateral views. These views minimizes the distortion of the heart size by positioning the heart closer to the film. The portable chest X-ray is an X-ray where the equipment is brought to the bedridden patient. This can occur in the ER, ICU, or the general ward. The portable chest X-ray radiographs are usually of less quality than stationary chest X-rays. They are usually shot in the anterior to posterior view. Portable chest X-rays are good for following a patient's progress. For example, they are good for tracking an infusion or for determining the position of a line placement. Other supplemental films include oblique, lordotic, and left or right lateral decubitus views. As for any imaging study, it is always important to try to obtain a previous study that can be used for comparison. On your left is a CT reconstruction of the bony thorax. On your right is a PA view of a chest X-ray. Visible landmarks are labeled. This includes a clavicle, rib, intercostal space, and vertebral column. On your left is a CT reconstruction of a lateral view of the bony thorax. On your right is a left lateral view of a chest X-ray. Visible landmarks are labeled. Notice the sternum, ribs, and vertebral body. The anatomy of the airways is outlined here. Notice the trachea bifurcating into the right and left bronchi. The borders of the right upper lobe of the lungs are outlined in PA and lateral views. The horizontal fissure separates the upper lobe from the lower lobe. The borders of the right middle lobe of the lungs are outlined in PA and lateral views. The oblique fissure separates the middle lobe from the lower lobe. The borders of the right lower lobe of the lungs are outlined in PA and lateral views. The borders of the left upper lobe of the lungs are outlined in PA and lateral views. The oblique fissure separates the upper lobe from the lower lobe. Note that the left upper lobe includes the lingula. The borders of the left lower lobe of the lungs are outlined in PA and lateral views. Outlined in green is the visceral pleura. The visceral pleura of two adjacent lung lobes make up the fissures. The parietal pleura is outlined in red. This thin tissue covers the interior of the chest wall and the diaphragm. Note that the parietal pleura and the visceral pleura are normally so close to each other that there is no real space between them. There is only a potential space, which is not seen unless the parietal and visceral pleura are separated by fluid or air. The diaphragm is composed of the right and left hemidiaphragms. They are normally dome-like structures. On the PA view, the right hemidiaphragm is usually higher than the left. This is due to the presence of the liver right under it. Notice the sharp costophrenic sulci. On the lateral view, notice that the heart sits on the left hemidiaphragm. This can help differentiate between the left and right hemidiaphragms. The cardiovascular system is outlined here on this PA chest X-ray. Notice the borders formed by the heart chambers and the great vessels. Shown here are the normal outlines of the superior vena cava, the aortic arch, and the right and left pulmonary arteries. The cardiothoracic ratio is equal to the greatest transverse dimension of the central shadow over the greatest transverse dimension of the thoracic cavity. This is shown as A over B in the corresponding image. In a good quality erect PA chest X-ray film, a cardiothoracic ratio greater than 0.5 is considered abnormal. Possible etiologies include cardiomegaly, pericardial effusion, poor inspiratory effort, low lung volumes, and pectus excavatum. This is a lateral view outlining the cardiovascular system. Notice the ascending and descending aorta. When reading a chest X-ray, it is important to assess the technical factors. First, identify the name, MRN, and the date of the study. Then check the markers to identify the orientation of the film. Next, assess the position of the patient. The medial ends of the clavicle should be equidistant from the midline spinous process if there is no rotation. Next, assess the film's exposure. If the thoracic spine cannot be seen behind the heart, then the film is too white and thus underexposed. Finally, assess the degree of inspiration. A deep inspiration is required to obtain a good image of the lungs. When the 6th anterior ribs or 10th posterior ribs are visible, the study is considered to be taken with an adequate degree of inspiration. When reading a chest X-ray, always use an organized approach so that nothing is missed. Correlate the findings on the PA view with the lateral view. During your search, identify the soft tissues, the upper abdomen, the bones, the mediastinum, the hyla, and the lungs. The end.